This is Jeremiah Piper, and you're listening to Science from the Source. In today's episode, we discuss how lifestyle factors, specifically physical activity and exercise, could help prevent age-related cognitive decline and dementia, as I speak with Dr. Belinda Brown, who is an NHMRC National Institute of Dementia Research Fellow here at Murdoch University. Belinda outlines her recent paper, BDNF, Val-66 MET moderates the relationship between cardiorespiratory fitness and memory in cognitively normal older adults. And then she talks about her current and future research agenda. Belinda, thanks for coming on the show.
Hi, good to be here.
Today we're going to talk to you a bit about your PhD and your current fellowship. You're an NHMRC National Institute of Dementia Research Fellow. You're working here at Murdoch University, and you're working in the area of exercise in dementia. And we're going to talk about not only your fellowship, but also a paper that you have in preprint at the moment, which is titled BDNF Val-66 MET moderates the relationship between cardiorespiratory fitness and memory in cognitively normal older adults. But before we do any of that, I just want to, you are an early career researcher.
Yep.
You are how far out of your PhD?
5 years.
And I wanted to maybe talk to you a bit about how you got into this area of research.
Sure.
What it is about this area that's made you want to continue on for the last 5 years, and then get kind of an idea of the fellowship that you're a part of. So,
Yep.
If you wouldn't mind speaking about that.
So out of my PhD, I got a 2-year fellowship from the Dementia Australia Research Foundation. And that was a partial salary fellowship that was topped up by the university that I was at, ECU. And in this particular time, I used it to contribute to long, ongoing observational studies, so continue to work on some studies I'd been working on during my PhD, as well as trying to get my own research happening. So that was working with yourself to establish some pilot intervention studies looking at high-intensity exercise in healthy older adults, looking at cognition. And it was that time that I established these pilot studies that got me the next fellowship, which is a 4-year fellowship from the National Institute of Dementia.
And two things. Well, first, I probably should have prefaced this by saying that I know you quite well and we work together, so it's probably a little bit a bit of a trick that I already know most of the stuff you're doing. But you said you were working with some through your PhD and coming into your first fellowship. You're working with some big longitudinal-based studies.
Yeah.
Those are here in Australia, right?
Yeah, yes. So the biggest one, the one that my PhD was based on, was the Australian Imaging, Biomarkers and Lifestyle Study of Aging, also known as the ABLE study. And in that, I used all of the observational physical activity data from questionnaires and actigraphs to examine the relationship between physical activity and cognition and measures associated with Alzheimer's disease in the brain and the blood. And I continued to work on some of that data after I'd finished my PhD, and I'm still involved in that particular study on the management committee. Also within our larger research group, we have an ongoing memory study, which is quite similar to ABLE, but very WA-based and quite open to including lots of different people from the community. And I also have been involved in a ongoing international collaborative study where we look at people with a dominantly inherited form of Alzheimer's disease. So quite a few different ongoing projects that I've been involved in the past.
So for ABLE and the memory study, both Australia-based longitudinal studies, how long have they been going?
ABLE started in 2007. And the memory study, I believe, commenced in 2001 or 2002. So they've both been going on for a long time.
And what's the ultimate goal of those studies?
To track people for a long time, importantly, because a lot of projects say the really large observational projects will see people in possibly 30 or 40 years ago and have seen them once and gotten, say, their lifestyle then, and now they follow them up 20, 30, 40 years later. Whereas in these studies, we're seeing people every 18 months doing a full evaluation of their blood, their cognition. A lot of these people are getting brain imaging done. So it's a really, really comprehensive long-term look at older adults in Australia.
And for someone who doesn't know anything about what you do, why would it be important then to track over such a long period of time?
Because we know, particularly when we're looking at something like Alzheimer's disease, that the pathology in the brain, so those proteins in the brain that cause Alzheimer's disease, can build up to 20 years before any symptoms are seen or someone even presents to their doctor. So what we're thinking is we really need to understand what someone's clinical profile would look like during those, say, 20 years when that pathology is developing. And we can actually measure that pathology using brain scans.
Okay. And that, I guess, leads on to my next question is you mentioned that your area of interest, primary area of interest, is with healthy older adults. And so if someone's healthy, I guess the question they might ask is why would they care?
Yep.
So why are you focused so much on healthy adults and not those who already demonstrate cognitive decline or those who are already have dementia?
So it's likely for that very reason that it takes so long for the pathology to accumulate. And what we think is that by the time someone is presenting with symptoms, so they go to their doctor and they say, look, my memory's really bad, my wife or husband keeps complaining about it, it's likely that too much damage has been done to the brain to reverse it. So we want to get in and intervene before people have that damage to the brain. So we want to reduce those levels of the protein before the brain cells significantly start to die off.
All right, and your area that you're interested in is specifically delivery of exercise or physical activity. Yep. Are there other areas, and we'll talk a lot about that in a second, but are there other things that people can do that might help with some of that early lifestyle factors?
So working with some of my collaborators at ECU, Dr. Stephanie Rainey-Smith and Dr. Samantha Gardner, they're really interested in looking at the role of diet and sleep and how that can be important in delaying Alzheimer's disease. So when they're looking at diet, really focusing on the Mediterranean diet. So that involves good oils, fish, moderate consumption of alcohol, minimal red meat, and moderate dairy. And with sleep, looking at things like really good quality sleep. So things like a number of interruptions throughout the night can be associated with poorer cognition, and a decent duration of sleep. And I think that they look at 6 to 8 hours as being the optimum amount of sleep as well.
Okay, so it's not just about getting sleep, it's about getting good quality sleep.
Yes, that's right. And we've also shown that the time it takes to fall asleep is associated with how much toxic protein is in the brain. So people that are taking a long time to fall asleep have high levels of that toxic protein associated with Alzheimer's disease. And
so in terms of, again, your area of interest is physical activity. So let's say someone's not as physically active as they should be. And let's say someone is as physically active as they should be, but they have poor sleep quality. Is there the same impact of poor sleep or poor physical activity over time? So if you start having bad sleep, does this pathology accumulate faster than if you weren't being physically active, or are they kind of just all on the same continuum?
Yeah, that we don't know. So nobody's done a study yet that I know of that's looked at all of these factors together and kind of looked at the long-term effects of them and compared the long-term effects of them. So that would be something that would need to be done in the future. But a lot of research is really turning towards an integrated lifestyle approach rather than comparing the different lifestyle factors.
What would you say is the biggest blockade to something like that actually happening, a study that takes into account sleep, diet, exercise and an intervention that then looks at all three of those?
Particularly with diet, it's so hard to do a diet intervention to completely change the way people eat would provide giving them food, making sure they eat only that food. So that is quite difficult. And sleep, the interventions being looked at the moment are associated with trying to change people's sleep behaviour. So that's also slightly more difficult to really control. Exercise, fortunately, is one of those things that you just get people to do it, they've done it, and that's it. Whereas interventions for diet and sleep are a little trickier. If it could be delivered, it would need to be done on a pretty high scale, large cohorts, over a long period of time, equaling a pretty large sum of money to run a study like that.
That's fair enough. The reason I ask that is that I think sometimes when we start talking about research in a a more generalized sense. There's always the idea that, well, without interventional studies, we don't know whether things are actually cause and effect. But it seems like for something like sleep and diet and physical activity for some part, that some of the best information that we can get comes from observational studies and making just kind of a general connection between those. I mean, would that be something that is true? Or
Yeah, for the diet evidence, most of the information's come from observational studies and sleep as well. And with physical activity, that's where the most robust evidence has come from, and that's where we found the strongest link between physical activity and Alzheimer's disease risk. The intervention studies haven't been quite as successful.
Okay, and what do you think, what would you contribute that to, so the lack of success in intervention studies?
We think it's likely a big part of it is due to the exercise being delivered, that it's really not of a high enough intensity or high enough volume to create any neural changes. And also it could be cohorts that are being looked at, particularly a lot of them are looking at people in the later stages of the disease that have high amounts of pathology, and really administering exercise to these people is great for things such as quality of life and mood, but we really might not be seeing any cognitive changes in those people based on introducing exercise.
And that makes a nice segue, I think, into your paper that we're going to discuss.
Yes.
And again, we're going to be looking at your paper that's in preprint. So that means that it's not technically, it's not published yet, but it's in a service that allows people to read it and make comments about it. It's titled BDNF Val66 MET moderates the relationship between cardiorespiratory fitness and memory in cognitively normal older adults. If you wouldn't mind just taking a few minutes to kind of walk through why you did the study and then what it was that you looked at and then what you found.
Yeah. So probably best to start with what BDNF is. It's brain-derived neurotrophic factor, and this is a factor in the brain that we know is mainly acts in an area known as the hippocampus, which is vital for learning and memory. And this particular factor is known to essentially keep the brain cells alive and talking well to each other. The Val66 MET is representing what we call a single nucleotide polymorphism, a genetic factor, and that particular genetic factor means that some people have a letter changed to another letter. That's pretty much what that means. And it's believed to have a functional outcome where the BDNF in the MET carriers is not released as well as in the Val-Val homozygotes. So what we looked at was whether fitness was associated with memory in a group of 99 cognitively healthy older adults. And we wanted to see if that genetic factor moderated the relationship between fitness and memory in those older adults. In particular, so we know that those MET carriers are likely to have poorer memory performance. And specifically, we wanted to see if fitness could mitigate that effect. And we did find that those that had higher cardiorespiratory fitness, but also had this negative genetic factor, were performing at the same level as those that had the good genetic factor. But those with lower cardiorespiratory fitness and the kind of at-risk genetic factor were performing much more poorly on a memory task than everybody else.
Okay, so you use cardiorespiratory fitness as your indicator of overall fitness. So why did you use that as opposed to a lot of the other studies that you looked at or you published have looked at the idea of just doing the amount of physical activity somebody's doing? So why cardiorespiratory fitness and not the amount of activity or the volume or the intensity of activity?
Yeah, so this is a purely objective measure. The studies in the past that have done almost exactly the same analysis have used self-reported physical activity levels. So this can have a lot of bias, a fair amount of error when looking at such small groups of people. Over-reporting of physical activity, under-reporting. So you may not be capturing the exact amount of physical activity that people are doing. But when we're looking at cardiorespiratory fitness, we're really seeing that biological effect that physical activity has had on a person.
Okay, and so would it be safe to say one of your hypotheses is that the fitter you are, the more BDNF you might have in your system, and that BDNF then, of course, you said is used for brain health.
Yep.
So for someone if someone doesn't know what BDNF is, and we explain what it means, but where does it come from? So how is that related to then fitness?
Yeah, so it's in the brain, but it's also circulating. It comes from the muscle and it's stored in the platelets. But they do think it crosses the blood-brain barrier, and that's quite important when we're looking at particular biomarkers of brain health. So during exercise and when BDNF is measured quite acutely after exercise, it's shown to increase significantly.
What about over prolonged periods of time, though? So if you're training and you're doing exercise, so let's say you listen to this podcast and for some, and you decide tomorrow you're going to go out and start exercising because you want more BDNF. What about over time? So if it works acutely, and we have some studies that have shown with resistance training acute increases in BDNF.
Yeah.
What about if I was to do 12 weeks of exercise? If I then measured my BDNF in my blood, would it be higher, lower?
I think that's still under debate. There's a few studies, there's a number of studies in the acute phase that are looking at that, and they show it repeatedly. It's almost fact that they continue to show it constantly. But in terms of actually changing the basal levels of BDNF, that has not been consistently shown at all. So we really don't know if the effect on cognition is just from repeated acute increases in BDNF or long-term increases. But particularly when you're measuring things in the blood, it's very tricky to get good measurements of things like BDNF, as a lot of factors can affect what the kits are actually picking up.
Okay. And is it possible that over a prolonged period of time, you don't see it in the blood because maybe it's being taken into the brain at a faster rate? Or is that something that's theorized to be? It's possible,
yes.
But of course, we can't determine that in humans.
No, unfortunately, in humans, the brain is a very sacred area.
Yeah, that's a fair point. Now, I know that some studies then use like CSF, cerebral spinal fluid.
Is very difficult to measure in CSF and has not been shown as a good biomarker for anything, unfortunately.
Okay. So CSF hasn't been shown for a good biomarker.
No, not with BDNF in particular.
Okay.
Yeah, with other proteins it's excellent, but with BDNF it has not been shown to be effective.
Okay, and with this Val66 Met versus the Val carriers, is there a normal proportion of the population who might have this?
Yeah, so about 20 to 25% of the Caucasian population would be Met carriers. So that's the kind of negative or risk genetic factor.
And that brings up another genetic risk factor for Alzheimer's, and that's APOE status. And can you maybe discuss that a bit? Because I know you bring it up in some of your papers, and maybe discuss it in terms of its prevalence as compared to this prevalence and what that all might mean.
Yeah, so APOE is the greatest genetic risk factor for what we call sporadic Alzheimer's disease. It's quite different from genetic mutations that cause Alzheimer's disease, and those ones are very rare. But in APOE, there's 3 different alleles or 3 different flavours. There's E2, E3, and E4, and E4 carries genetic risk for Alzheimer's disease. And again, about 25% of Caucasians will carry the E4 allele. And there is some evidence that there's a synergistic effect between E4 and Met carriage, that if you carry both, you're in a fair bit more trouble.
Are these, I know that we use these for research purposes, but are these different genetic factors used as diagnostic purposes currently, or is it just something that we see in research that we're not 100% certain?
Yeah, generally in Australia, these type of genetic factors won't be, you won't be sent by a doctor to get tested for them. But we are seeing an increase, particularly in the US, with these genetic companies where you send off a swab and get your report back. And some of them are including APOE in them, which you might think could possibly be concerning with people as they get older, being worried about their risk of Alzheimer's disease and maybe taking things into their own hands. And
again, though, when we talk about APOE4 status, it's risk. It doesn't mean you're going to...
Absolutely,
It's going to translate. So is there instances then when people who have APOE4 don't become...
Yes.
Don't go down the path of dementia?
Yep. People without E4 can go on to get dementia. People with E4 may not get dementia. So it's definitely not a cut and dry. It's very clear that it is a risk factor, not a definite factor. And again, lifestyle, in particular physical activity, is shown to modulate that risk of carrying the E4 allele.
And can you just explain that a bit more? So, I mean, if you're saying that APOE status might be something that you could get in a genetic test, and that might be something that comes to you, and you might be a bit worried about it. Whether you should be worried about it or not is a different story. But you're suggesting then that maybe engaging in physical activity might be able to offset some of that risk?
Yep. So a number of studies looking at long-term Alzheimer's risk, the toxic protein in the brain that causes Alzheimer's disease, and cognition have all shown that the E4 carriers benefit the most from exercise. So they're a lot of the time more likely to bring their risk back to normal, rather than have that higher risk if they're doing high levels of exercise.
More of a general question, just in terms of, and I know you're not a clinical psychologist, so you may not be super comfortable answering this, but you talked about earlier on about maybe people whose memory might be failing, and by the time they kind of realize that it could be, and if it is dementia, it could be that the pathology is already in place. If someone, how do they make the determination in the first place? So if I think my memory is failing, right, and I forget things all the time, when do you think it really is a problem? I mean, when do you think that's something that you should be actually concerned about, and what types of things should you or your partner be more interested in terms of memory and failing memory?
Yeah. And yes, full disclosure, I'm not a clinician of any kind. But by presenting to a doctor with memory problems, they'll generally do a very quick cognitive test to see how you're going. A lot of the time, they will ask for corroboration from your spouse or somebody that knows you really well, who is usually the first person to notice that something is really quite wrong and quite out of the ordinary, because a lot of the time the person experiencing the memory problems won't have a huge amount of insight into those problems. And from there, they tend to do diagnosis based on exclusion, still with Alzheimer's disease. So they'll make sure that nothing else is causing the memory problems, such as, I think, things such as depression, low iron levels, thyroid issues can all have quite acute effects on cognition. And then once they've excluded all of that, then they can go down the path of looking at the diagnostic criteria for something like mild cognitive impairment, which is a pre-dementia phase, or a specific dementia diagnosis.
That brings up a good point. So let's say someone does go into the doctor and they are diagnosed as having mild cognitive impairment, so their memory is poor enough to result in that kind of diagnosis. What's the literature say about the use of exercise in that population? In that particular population, it's very strong. There was a study 10 years ago now looking at simple walking intervention, and they showed that stopped the decline in memory in people with mild cognitive impairment over an 18-month period, compared with a group that weren't doing any exercise. And more recently, there's been a study looking at progressive resistance training, and that showed an even greater effect at attenuating decline. It actually improved their overall cognitive scores over 18 months by doing progressive resistance training. Is this something that you would have to keep up for the rest of your life, do you think? I mean, and I know that there's no studies that have looked at full life. So, I mean, if you're thinking about this in terms of just, let's say maybe you're working in the field and you're prescribing exercise, or maybe you yourself are concerned about your memory, is this something that can be fixed with a 3-month intervention, or do you think it's something that you're going to have to just, for the rest of your life, engage in something that's quite good for you in the first place, but continue to engage in exercise? Yeah, it looks like it is something that you have to do over a long period of time. There is evidence that a short intervention can have longer-term effects, but there's no evidence to suggest that those people didn't go on to keep doing the intervention, and that's why they had the longer-term effects. So we're still not sure in that sense, but it looks like it will be a longer-term effect. Okay. And I know that you've been, and we're kind of getting off topic here, but I know that you've been involved in a fair few other studies that have looked at other type of lifestyle interventions. And one of the more common interventions that you see commercialized is brain training and brain games and puzzles. How relevant do you think those are? And I know, again, you're not a clinical psychologist, it's not your area, but I know that you've been kind of involved in some of those studies. If you were to compare those outcomes to what you see in terms of the exercise-based literature, how do they compare? It's quite variable based on the program that is used.
I know a colleague of mine, Dr. Tejal Shah, did a pretty substantial review on the available programs for cognitive training, I think published in Translational Psychiatry a few years ago. And I think it's the evidence for maybe one or two very evidence-based programs. So things like downloading an app and playing the games a few times a day probably only makes you better at playing those games. But some of them are very strongly evidence-based and have a quite integrated approach where they're using various cognitive domains in the same game. So training a lot of different parts of your brain at the same time, and they're the ones that have been shown to have an effect on your cognition.
Okay, so it may be that you need to, if you're going to use some type of brain training, it needs to be a program that has multiple ways to stress cognition, as opposed, like you said, just really focusing on maybe acute memory or something like that. It needs to be focusing across the board.
Yeah.
And we're going to get in a second to, I want to talk about where you think you're going to go from here. You're currently in the midst of your fellowship.
Yes.
And you have a bit of time left in the fellowship now?
1.5 years left.
Okay, so 1.5 years left of fellowship, so you're feverishly writing grants, trying to find the next fellowship.
This is right, yes.
So where is it that you want to go with your research? So it's obvious that your area of research is physical activity and dementia, but what is it that you're hoping to achieve? And then maybe we can talk about some of the projects that we don't have to go in depth what you're going to do, but what is it that you're trying to achieve in the next, let's say, 3 to 4 years?
Yep. Ultimately, I'd like to do an exercise intervention that doesn't have any shortcomings. So there's been so many large studies that have come out with such varied results, and every time they come out, people pick them apart and say, well, their exercise wasn't intense enough for the cohort that they used. There was something wrong with that. It would be really nice to take all of those issues and design a study where we can say, look, these are the results and we think these results are actually real, and use those for recommendations, rather than continuous studies keep coming out with so many issues that we can't apply to recommendations.
That's an interesting point. So you mentioned that a lot of the studies might not be intense enough. And so if you take the advice of the World Health Organization, right, and they say 150 minutes a week of general walking, in a few minutes ago we talked about an MCI study where they just did some walking over time. Why do you believe that intensity is so important? I mean, so is it good enough? You're saying it's maybe not good enough just to go out and walk, that you might need to be walking. Now, I'm assuming you don't mean they need to be going out and doing 100-meter sprints all the time, but why do you think intensity is so important?
BDNF is a major factor there. So the more intense the exercise, the greater increases in BDNF following exercise. And also a lot of the observationals data that's looked at moderate intensity versus high intensity exercise. It's showing that high intensity exercise is having a greater effect on cognition and the brain in general. So that's what that's mainly based on.
Then when we talk about high intensity, what does that look like? So my whole entire area is around exercise.
Yeah.
So when I say high intensity, I have a very defined idea of what I think it means. But what do you see it as?
Yeah.
And so if someone's asking you what they should be doing for exercise, what do you think they should be doing?
What I found interesting was that it's not going as hard as you can. With the trial that we're doing at the moment, it's they cycle quite hard and get their heart rate up quite high, but they're able to do that for a minute. So it's high intensity, but it's not kind of pushing yourself to the absolute edge, if that makes sense. In the observational study that I did on high intensity, using an actigraph, what we saw with the people doing higher intensity exercise or physical activity had better cognition. And to get into that high intensity threshold, that equated to brisk walking. So it may not be particularly high intensity, but more than just that kind of casual walk around the shops or walk around the park. And of course, it will totally vary from person to person.
Okay, and two things. I mean, that's an interesting point. I was just reading something you wrote the other day, as a matter of fact, and we're talking about just the difference between physical activity and exercise, and that physical activity tends to be sporadic, and it tends to just be something you do. You get up, you go around the shops, this and that. We can call that physical activity, but you made the point, you may need exercise to get to that high intensity. So while brisk walking might be what is considered high enough, it may not be something you normally do.
Yeah.
Right. So it might be that that exercise is something that's very structured might be more necessary to reach those target intensities.
Yeah.
And that brings me to you mentioned a study you're currently conducting about high intensity exercise, and this is part of your fellowship.
Yes.
And this is been going on for.
I think about a year and a half. Yeah, beginning of 2017, so almost 2 years.
Okay, so almost 2 years, and this study is looking at the difference between moderate intensity and high intensity exercise and
Yes.
cognition and a range of other factors. So what else are you looking at in that study?
So we're doing MRI scans on everyone. So we're looking at the volume of the brain and also the connections within the brain. So during rest, so looking at how the brain works at rest, and also under a task, so getting them to do a rather difficult cognition task, and we're seeing how their brain works during that, and measuring it before and after the 6-month exercise intervention of either high intensity or moderate intensity cycling.
What's the difficult task?
It's called a 2-back task. I didn't think it was that difficult when I chose it. But having implemented it under a scanner in a number of people, it is very difficult. So what they have to do is they're shown a letter on the screen, say it's A, they're shown another letter, say it's K, and then the next letter, they have to say whether the one 2 back is the same as the one they're seeing now. And then they're continually shown letters for 40 seconds, and they have to continually say yes or no as to whether it's the same as the one that's 2 back.
And what area of cognition does that?
That's working memory, so a type of executive function. So executive function being kind of the higher cognition, it kind of controls everything and is really associated with quality of life.
And how soon into the decline in cognition is executive function?
Very early. It's one of the first, along with memory, to decline in Alzheimer's disease.
Okay. And so you're looking at the difference between moderate and intense physical activity. And like you said, it's fairly intense. And I helped design the program, so I know it's quite intense. And they're doing this 3 days a week for...
Two days a week for 6 months, yeah.
So look, I didn't design it all that well because I don't even know what it is you did. So 2 days a week for 6 months. And how many subjects have you completed?
99. So we have 3 groups, 32, 33, 34. In each group, we've got the high intensity, moderate intensity, and then a control group that doesn't do any exercise.
Okay, and this has all been happening here at Murdoch University?
Yes, yep.
And you're pretty close to start looking at the cognitive data.
Yep.
Is that correct?
Yep, within the next few weeks.
Okay. Have you had any outcomes from the study at this point that beyond? I mean, we have some fitness changes at this point, but you're still working on MRI outcomes. And stuff like that?
Yeah, nothing to report just yet.
So where would this study then fit in with the current body of literature? So you mentioned that what your goal is for the next 3 to 4 years is to produce studies that have few limitations. So limitations being, you mentioned the intensity of exercise, the cohort you're looking at. Where do you think this study stands in that idea? Yeah,
so there's the limitations for this one would be that we haven't integrated any resistance training, which is shown to be pretty important in this field. And the sample size is relatively small as well. So those would be probably the 2 major limitations that we would want to address. And also there's really quite advanced brain scanning out there that we can look at particular proteins associated with Alzheimer's disease. So using that kind of technology would probably really advance a study like this. But in terms of fitting in the current literature, I think it will contribute a fair amount as there hasn't been a specific high-intensity interval training trial in cognition with such rigorous outcomes from brain scanning MRI.
I know you just listed off a bunch of limitations when there's not. I mean, that it makes it sound like the study is not good. What do you think the major strengths of the study are? Because I mean, again, I am part of this, so I think it's got a strong outcome. But what would you say the major strengths are of this study design? It's been going on for 2 years. You know, why when it comes out should people want to read this and try to get this knowledge?
The major strength is that all of the exercise is supervised. So we know exactly how much every single person has done at every single session. So we can quantify that rather than other studies that send people home with a list of things to do, a bit of equipment, and give them a call every couple of weeks and check on them. We specifically know how much exercise people are doing, so we can say this amount of exercise had this effect or this amount of exercise had no effect. We can actually make that statement.
Now, you say it's a relatively small sample size, and yes, in terms of, again, some maybe larger epidemiology-based studies, but where does this sit in terms of current intervention studies? So are there intervention studies that are as kind of controlled, as similar controlled as this one with the same number of people or larger people? Or is this kind of somewhere in the middle or at the lower end?
Yeah.
What do you mean by small sample size?
This one sits somewhere in the middle. If we're talking about MRI studies, it's pretty spot on. If we're talking about cognitive studies, it's, yes, somewhere on the lower end. But the biggest study in this field to date, still the one from 10 years ago, had, I think, 85 in each group. So that was significantly larger. But when we're looking at a lot of MRI studies, they'll have 30 to 40 people in each group.
And finally, you did mention that this study, well, you said one of the limitations, again, I still don't think it's a limitation. I think that it's just, you're looking at the idea of aerobic exercise and intensity, but you mentioned that it doesn't have a resistance component to it. And then a little bit before that, you mentioned that there's been some resistance training studies where they use progressive resistance training in MCI patients and showed really nice results. What is the difference? I mean, what would be the difference in mechanisms between the aerobic versus, we'll call it non-aerobic or resistance training, that means that you might want to look at interventions that have both to complement?
Yeah. Well, with the resistance training, it's interesting with that there's a particular factor called IGF-1, insulin-like growth factor 1, and that seems to have the biggest effect with only resistance training, and that has a lot of beneficial effects on the brain, very similar to BDNF, and quite an integrated effect or synergistic effect with BDNF. So it's believed to get the full benefit from both BDNF and IGF-1, you should probably do both to get that kind of enhancement. But in terms of the effect of resistance training on the proteins associated with Alzheimer's disease, we're really not that sure. Not a lot of research has gone into it. But we know the mechanisms behind aerobic exercise, cardiovascular, BDNF increased cerebral blood flow, and hopefully lowering those toxic Alzheimer's disease proteins. But with resistance training, we're not as sure, except for those neurotrophic factors like IGF-1 seem to be more increased.
And when you're talking about the proteins, are you talking about beta amyloid?
Beta amyloid and tau, yeah.
Okay, and so you're suggesting that while resistance exercise shows beneficial effects, some of the biomarkers that might help cognition, but there's nothing really at the moment that's looked at the proteins, or is it just there's not any data to support?
There's not any data to really support it yet.
So we're getting towards the end of the interview, so
yes.
It goes that fast. But I want to ask a couple extra questions here. I asked you what you kind of want to do with your research in 5 years, and your response was to produce high quality studies, and that's a very good answer, I think. I think that would be a fantastic way to go. But what is it that you think you want to do? What is your hope that you can do with your research, I guess, across your career then?
To be able to provide enough scientific evidence for it to be clinically used. And not just that there's enough evidence, but to make sure it's actually taken up within a clinical setting. So there's no use having all of this research evidence when it's not being translated. So to really be able to provide the evidence as well as following through and making sure that the primary care providers really know that exercise is important, not only in the prevention, but in the treatment of people with MCI and dementia. And just making sure that message gets across. But of course, as always, they really need substantial evidence without the limitations that the previous studies have had.
How far away do you think we are from that right now? I mean, where are we? Anywhere in the ballpark of that happening?
Yeah, I mean, I don't see why it's not something that could be talked about now, with the caveat that more work is being done and we can provide more specific recommendations in, say, 5 years' time. But it's definitely a conversation that can start now.
And so is it something, I guess, if I was 65 years old and I had memory complaints, I went to my doctor, would my doctor know that exercise is a beneficial strategy? Or do you think it's something that we're still kind of fighting that fight to get that into clinical practice?
It's not listed in the dementia guidelines for Australia currently, the clinical guidelines that are provided. So probably not. No, unless they're very well read and up with the current literature. For doctors that just follow the current clinical guidelines, the only reference to exercise is just continuing to be active rather than starting a new specific regime.
Okay, and I mean, I don't think there's any slight towards you. I just what I want to know. I mean, I know that within cardiovascular health, heart health, it takes a long time for recommendations to be taken up by clinicians, and so you're working your way to getting those recommendations kind of in clinicians' heads. But even if there's not a major cognitive benefit to exercise, do you think that exercise should play an important role anyways in someone who maybe is MCI or has dementia?
Absolutely. It's been shown time and time again to improve mood in people with MCI and dementia, reduce falls, improve behavioural symptoms, and generally increase quality of life. So those things alone, I think, is good enough reason to essentially prescribe exercise.
Great. So I do have one last question for you. So someone may be listening to this podcast and they may be interested in what it is you do. You're constantly running fairly large studies here at Murdoch, and so maybe they want to be involved in those studies. If someone wanted to contact you or get information about what it is you're doing or what you have previously done, how would someone get in contact with you?
Would you like me to give my email address?
You could do that if you want. Don't give me your phone number, so just your email address.
Email is the best way, and it's b.brown@murdoch.edu.au.
And if someone who doesn't want to email you and they want to maybe send you a message on Twitter, do you use Twitter often? And if you do, how would they get in contact with you there?
That's a good question. My Twitter handle
Take your
that
time.
I do not know.
I'll just edit this all out.
At Dr. Belinda M. Brown.
Great. So if someone wants to follow you that way, they can, or they can email you directly. Are you currently looking for any participants or putting together any studies that might be needing participants in the future? Possibly
in the future. Yes, hopefully. We will be running some big studies.
Easy. So that is it. We are all finished. I do want to just finish off by thanking you for coming down. I know your office is only one floor above, and it was a big, long walk. But I want to thank you for coming down and having a discussion about your area of research. I mean, I don't have to explain how important it is. I think that anybody who listens to this would understand how important it is. But I think your desire to produce very high-quality studies is what's more important. So, again, just want to thank you for coming down, and I hope you enjoyed the experience.
You're welcome. Thank you.
That concludes another episode of Science from the Source. If you enjoyed the podcast, please help support the show by telling your family and friends. If you would like to contact me to discuss the podcast or any of the content, please feel free to contact me via Twitter at Jeremiah Pfeiffer or by email at sciencefromthesource, that's all one word, @gmail.com.